afternoon and good evening to all distinguished speakers, chairs, and the wonderful audiences of the ACNS webinar. Today we will hear two very important topics with our own very learned speaker and chairs. The speaker for the first session today webinar is our honored guest from Belgium, Professor Christian Raftopoulos. Professor Raftopoulos is the professor and head of Department of Neurosurgery, St. Luc University Hospital, Brussels, Belgium. Professor Raftopoulos' scientific contribution include the development of the new classification of intracranial pressure wave and development of modified surgical technique of Chiari malformation, meningocele, and intracranial aneurysm. Currently, Professor Christian Raftopoulos is particularly involved in the epilepsy surgery and new minimally invasive spine technique. His considerable work is reflected in the more than 100 articles of which he is author or co-author that have been published in peer-reviewed journal. He was the past General Secretary and the President of the French Language Neurosurgery Society, also known as the Société de Neurochirurgie de Langue Française, SNCLF. We are extremely honored today to have him as a speaker for our webinars, and he will be talking about vertical Paramidian Hemispherotomy for drug-resistant epilepsy. The speaker for the second session today is our honored guest from China, Professor Yu Jun. Professor Jun is the chief physician at the Department of Neurosurgery in Zhejiang University School of Medicine, Hangzhou, Zhejiang, China. His interests in neurosurgery are focused on neurovascular diseases, including intracranial aneurysm, vascular malformation, carotid artery stenosis, moya-moya disease, surgical intervention, treatment for neurovascular diseases. He is noted author with several publications in various peer-reviewed journals. We are extremely honored to have him today as a speaker, and today he'll be talking about endovascular treatment of blood blister aneurysm. The chair for the first session today is our honored guest from Switzerland, Professor Roy Thomas Daniel. Professor Roy Daniel is the chief physician at the Department of Neurosurgery at the Lausanne University Hospital, CHUV. Professor Daniel is a pioneer in pediatric epilepsy surgery. He has developed a new intervention technique based on hemispherical and subhemispherical disconnection. Professor Daniel has several ongoing clinical research projects in the field of skull-based surgery and vascular neurosurgery, both at Swiss and European level, as well as through international multi-center research projects. We are extremely honored to have him today to chair the session of our Professor Raftopoulos. The chair for the second session of today's webinar is our honored professor from Japan, Professor Yoichi Morofuji, Japan. Professor Yoichi Morofuji is a chief neurosurgeon in the Department of Neurosurgery, National Nagasaki Medical Center, Nagasaki, Japan. He was a previous senior fellow at the University of Washington, USA. Dr. Morofuji specialized in the microsurgery and endovascular treatment of aneurysm, AVMs, dura AV fistulas, stroke, carotid artery stenosis, and brain tumor. He is passionate about basic and translational research, focusing on blood-brain barrier. He has been principal investigator on several basic international research projects. We are extremely honored to have him today to chair the session with Professor Yu Jun. On behalf of the Education Committee and the ACNS, the President, Professor Yoko Kato, I would like to welcome both the speaker, chairs, and audiences to this online platform of ACNS. My name is Liu Bun Singh. I'm a co-host together with Professor Raja for today's webinar. With that introduction, I would like to hand over this online platform to our first chair, Professor Roy Thomas Daniel. Professor, to you.
Thank you, Ivan and Raja. I'm honored that you called me to chair this session, and extremely pleased that you asked Professor Raftopoulos to give a talk on epilepsy. As you know, Professor Raftopoulos trained with Professor Jacques Brochy, one of the pioneers of neurosurgery in Europe. He is the chairman at the St. Luke University Hospital in Brussels, which is part of the UCL, Université Catholique de Louvain. He has really brought up that department to a state in which it is one of the best known ones in Europe. Professor Raftopoulos has pioneered a lot of techniques in neurosurgery in Europe, and the one that he'll be talking to us is on epilepsy now. Particularly in epilepsy, he has done a lot of work on intracranial recording, surgery of insula, and particularly multiple subpile transections. But I'm very happy that he chose to speak on hemispheric epilepsy today, because that's an area that I am passionate about. And even more so because he's talking about vertical hemispherotomy. Now, since Professor Delalande in Paris pioneered this technique, there has been only a few reports of this in literature, and I'm happy that he's talking about the vertical hemispherotomy technique, because personally, I would really like to know how he compares that with the lateral, which is much more commonly used today in pediatric epilepsy surgery. So over to you, Professor Raftopoulos, and thank you for accepting this invitation. I look forward to your talk.
I'm starting my presentation. I would like to say that I'm very happy that Roy Thomas Daniel is my coordinator, because I know him since a long time, and I've read a lot of his papers, and I'm very pleased to see him today in perfect form, and I see forward to discuss about that in the next 45 minutes. You see the title of this presentation is Vertical Paramidian Hemispherotomy, and I would like to stress the fact that here it's a modification, and in the title I would like to stress the lateral to the lenticular nucleus aspect. So the name of that procedure is vertical paramidian hemispherotomy, but subinsular, and I will develop that point. So first, to make for the people who are looking at that presentation, the big difference between disconnection and resection. The history of that procedure started with a resection, and a resection is a huge thing. It's the first time I saw that, I was a little bit horrified, because removing a hemisphere is something very impressive and a little bit horrifying. And fortunately, a few people started to say, because of the complication of that procedure, to say that resection is not the best way to perform to help people with a drug refractory epilepsy, and we should go for a disconnection, a TOMY into the brain. And we must stress that the two first names to have brought that into the light was Professor Lane from Lille in France and Professor Rasmussen. And you see the big difference between a resection and a TOMY. All my presentation will be based on pictures coming from a wonderful book named The Human Central Nervous System, written and designed by Nieuwenhuis, Vogt, and Van Huysen, published in Springer. So I started, as everyone, performing perisylvian of transsylvian procedure, and I went to the vertical paramidian hemispherotomy for essentially for anatomical reason. So vertical paramidian hemispherotomy, according to Delalande, who is the guy who has described the first that procedure, is two main words: vertical, paramidian, and TOMY. Essentially a section of different pathways. And of course, performing that procedure, I thought that a few modifications could help me to do that better. And I will share that with you. So the first thing is that Delalande described his procedure by performing a central bone flap. I prefer to perform a precentral bone flap. That means that instead of going above and in the vicinity of the trolar vein, I prefer to center my opening on the coronal suture. So I do not have many venous drainage. Even if we know that we are disconnecting a hemisphere, I think, because I like also vascular surgery, I like to preserve the vein and the arteries. So the second point of the Delalande procedure is to perform a central Pallium corpus callosum resection targeting the choroidal fissure. I prefer to perform a precentral resection targeting this time the lateral border of the temporal cord. I will show you that. You see on the left side the pictures reported in the seminal work of Delalande. You see the resection of the pallium and the truncus and is section lateral to the thalamus, vertical to the choroidal fissure. I recommend to perform a truly vertical resection of the pallium and of the truncus of corpus callosum. When you arrive into the ventricular, I recommend to place a plug of gel foam into the foramen magnum to avoid contamination of the third ventricle by blood. And then, instead of targeting the choroidal fissure, my resection here must be performed so that I will be able to target the lateral border of the temporal horn, so that I will be able to go lateral to the lenticular nucleus or subinsular. Lateral to the lenticular nucleus, that means subinsular and not lateral to thalamus. So doing that, I try to keep intact as much as possible the lenticular nucleus. So lateral to the lenticular nucleus and not lateral to the thalamus. The third step is for the Delalande, go and perform the posterior corpus callosum disconnection, the splenium disconnection. I prefer to start with the disconnection of the anterior corpus callosum and performing not only the disconnection of the rhinu of the corpus callosum, but also of the rostrum. And you see here, this disconnection, I perform the disconnection of the rhinu. My landmark are the pericallosal artery and also the anterior cerebral artery, but I will go further posteriorly and perform a disconnection of the very small rostrum of the corpus callosum. So I go more posteriorly. Of course, a major landmark here is the foramen magnum, the foramen of Monroe and the anterior commissure. And behind that, the fornix. This fornix must be kept intact. You see the resection seen going from above, resection of the rhinu. The following step recommended by Delalande is to perform a gyrus rectus resection plus a lateral incision. I don't do that, I perform a SuperRostrom disconnection. SuperRostrom disconnection. You see that Delalande going through the rhinu will go and remove the posterior part of the gyrus rectus. Going through the rostrum, you will go more posteriorly and you will make a disconnection going through the Brodmann area 25. That means I will disconnect a much greater of more completely the orbitofrontal cortex going more posteriorly. A landmark there is, of course, the chiasm and the polygon of Willis, but essentially the chiasm and the optic nerve that you can see through the PIA performing that transversal disconnection. When you have performed that, you go posteriorly and you perform the disconnection of the splenium of posterior part of the corpus callosum. And there, the landmark is the great cerebral vein of Galen, performing the disconnection of the splenium up to the great cerebral vein of Galen, coming from the basal vein of Rosenthal and the internal cerebral vein. Next step recommended by de Lalande is to perform a disconnection of the crus of fornix. I think we have to do more than that. We have to perform the disconnection of the floor of the ventricular trigger. What is the floor of the ventricular trigger? When you have disconnected the splenium and you go to the temporal horn, what you will perform is disconnect the floor. That means the crus, of course. Crus is the continuation of the alveolus fimbria crus, and of course go to the body of the fornix. The crus is the junction between the fimbria and the body. The second thing that you will disconnect is the fascicular gyrus. The fascicular gyrus is part of the intralimbic gyrus. Is the junction between the retrocommissural hippocamp and the supracommissural hippocamp of supracallosal gyrus. And the third thing that I will disconnect is the posterior part of the parahippocampal gyrus, part of the lambic gyrus, which is the junction between the parahippocampal gyrus and the cingulum. So then you perform a disconnection of the fornix, of the intralambic gyrus, and of the lambic gyrus. You see that going in an operative point of view, going from the splenium to the temporal horn, disconnection of the crus, disconnection of the fascicular gyrus, and below the fascicular gyrus, disconnection of the posterior part of the parahippocampal gyrus. And you see here, disconnection of the splenium, disconnection of the crus, disconnection of the fascicular gyrus, and disconnection of the posterior part of the parahippocampal gyrus, part of the lambic gyrus. And when you do that, you will arrive superiorly to the perimesencephalic system, also named the ambient system. Next step, described by de Lalande, perform a disconnection vertical, posterior to anterior, lateral to the thalamus. I won't do that, I will do more or less the same, but lateral to the lenticular nucleus up to the piriform lobe, which is the most anterior part of the parahippocampal gyrus around the amygdala. Again, you see the technique described by de Lalande with that vertical disconnection lateral to the thalamus. And here, I won't do that. I will go lateral to the lenticular nucleus subinsular, and I will follow the lateral wall of the temporal horn. You see the pathway of that disconnection, posterior, anterior, subinsular, to my previous SuperRostrom transaction. You see Going along the temporal horn, you will arrive in the piriform lobe. You have to remove as much as possible the amygdala, which is surrounded by the piriform lobe, and you will go to transect the limen insula, in which you have the anterior commissure, you have the uncinate fasciculus, and you have the inferior occipitotemporal fasciculus. You see that on that description. You see very well here, more or less, this crucial connection between the frontal, insular, and temporal lobe that you have to disconnect to be 100% sure that you have performed a 100% disconnection. So I will show you a case. It's an 8-month-old female. And you see that this poor baby has had, since 1 month of age, 100 spasms per day. That child didn't have any visual contact with her family. You see very regularly a spasm of the whole body of that young child. The diagnosis was early infantile epileptic encephalopathy, also named Ohtahara syndrome. The cause of that early infantile epileptic encephalopathy or Ohtahara syndrome was what you see here, hemimegalencephaly, essentially of the parietal, temporal, occipital left lobe of the child. You see the EEG is a very, very active EEG. And when you perform the PET scan, you see that the megalencephalic hemisphere is particularly all the time hyperactive. I will show you a vertical Paramidian hemispherotomy on another child. This time it is on the right side. You see that I have already performed the disconnection of the HELU. I identify the foramen of Monroe because I want to be sure not to hurt the fornix. And I complete my disconnection by disconnecting the rostrum up to 1 centimeter from the anterior border of the foramen of Monroe. I will plug that foramen of Monroe with a gel foam. I see the anterior cerebral artery, and now I start the section of the orbitofrontal cortex just below the rostrum. You see my opening, 15 millimeter. I don't need more to perform that hemispherotomy. So the hemispherotomy will be performed through a 15 millimeter opening precentral on the hemisphere. Here I have disconnected the splenium. So keyhole surgery, the microscope is inclined, and now I see the crus. I am in the ventricular trigone. I coagulate the plexus so that I can see perfectly well the crus of the fornix. The right temporal horn is on that side. And going from the splenium, I start my disconnection of the fornix, of the intralimbic gyrus, and of the limbic gyrus up to the ambient cisterna. So I'm starting my section, posterior, anterior, as lateral as possible into the temporal horn, trying to keep intact the lenticular nucleus. I think that even doing that, I must lesion a little bit the putamen. You see the caudate nucleus, but the caudate nucleus is a good landmark, trying to go as much lateral as possible. Thalamus, lenticular nucleus in the depth. You see here, I have gone between the putamen, a little bit into the putamen, but certainly subinsular. And I go like that through a little bit of substance, of gray substance. I am here in the anterior extremity of the temporal horn, and I remove as much as possible the amygdala and the piriform lobe, and I connect my transversal section, rostral area transection, with my resection of the amygdala. To end the surgery, I checked all the hemostasis. You see perfectly here the plexus choroid on the right side, the thalamus, in the depth part of the lenticular nucleus. You see my opening, and I close my opening with gel foam. What is incredible is with that child with hemimegalencephaly, the day after surgery, the first day after surgery, I think surgeon performing hemispherotomy with case of severe epilepsy have also experienced that. The child looked her parents into the eye. There was the first eye contact between the child and her parents. And it is a wonderful gift to see the joy in the eyes of the parents. I think it's our first reward. You see the child a few months after surgery, that child with the hemimegalencephaly on the left side. So there is a hemiparetic right body, hemiparetic right body. And you see the arm is still moving, not the hand, but the arm is moving. And if you look at the right leg doesn't move a lot, but look at this. At some times, even a few months after that hemispherotomy, the right leg can move, and it will improve with the time. So a few months after surgery, it was 1 year old. Normally a child can walk at 6 months, but here, you know why. You see here a postoperative MRI, and this one is not probably the best, but I wait for another one with the last patient. You see the lenticular nucleus kept intact, and you see that the axis of my disconnection, even if this disconnection has been dilated by CSF and atrophy of the hemispheric cortex, the target was the lateral part of the temporal horn. And you see a child here, 12 years after the surgery, and you see how the nervous system can take in charge the motricity of the left body in that case. But again, you see, even if that child can move her left arm, the hand is a lot paretic. So the results, you see literature, mortality between 0 and 3.6%, rate of postoperative shunt between 2.5 and 14.4, angle 1 between 60% to 93. 94%. In my current series of vertical Paramidian hemispherotomy, 20 consecutive cases, 50% of these cases were Sylvian stroke, 15% of them were Rasmussen syndrome, 10% of them were hemimegalencephaly, mortality 0%, rate of change 10%, angle 1 95%. I would like to conclude telling you that the vertical Paramidian hemispherotomy lateral to the lenticular nucleus or subinsular appear to me more straightforward, with a high efficacy on the drug-resistant epilepsy, with a low risk of shunt. But regarding is that procedure can give a better functional recovery for the patient remain still a question. But what's clear is that procedure can help the patient to a second time rebirth. Thank you for your attention.
Yeah, thank you very much, Professor Raftopoulos. That was a beautiful description of the vertical hemispherotomy.
Thank you.
Yep. So before we go on to the questions from the participants, I have a few comments to make, and I'm very happy that you showed it, because I share your enthusiasm with the remarkable results that hemispheric epilepsy gives to children, and it is like magic. It is
absolutely.
It is the most gratifying part of epilepsy surgery. I have children who have now more than 20 years after surgery. Some of them have done their universities, and so it's the most gratifying part. I had a few comments to make on this and a few questions as well. Number one, when a long time back when I compared our results from Lausanne and India with Olivier Delalland's series with vertical hemispherotomy, one of the things we found was that the chances of having hydrocephalus was higher in the vertical hemispherotomy. I asked Olivier himself that question, and maybe the reason is that there's a high percentage of hemimegalencephaly in the Paris series. Does that explain? Maybe it does. Maybe it's because there is more brain manipulation, and therefore there is more debris that is released into the ventricle. That could explain that. I would like your comments on that. That's number one. And the number two was, and you raised the question as well, that the functional recovery is better with the modification that you made to take the disconnection lateral to the lentiform nucleus. And I think that is the key, because when we were comparing the lateral hemispherotomy technique that I have grown up with and published the most on, one of the things that we noted was that we were leaving the basal ganglia completely untouched. And maybe some of the proximal movements that we see in patients after surgery, which allows them to walk, to play sports even, except for the distal movement of the hand and the foot tapping, all other movements are there. And maybe that's because we are not disturbing the basal ganglia. And your modification to take the incision to the temporal horn, to the lateral end of the temporal horn, which is lateral to the lentiform nucleus and just under the insula, I think is one way to avoid entering into the ipsilateral basal ganglia. And I think you are right to say that the functional recovery is better because of that. I need your comments on that. And the third comment that I heard recently, well, a few years back from my colleague, Marc Levivier, who you know very well. You trained together with Professor Brocci, and he told me a funny story. I'll just share that with you. As when he applied for neurosurgery with Jacques Brocci, the first case he saw was an anatomical hemispherectomy. And Jacques Brocchi had put all the different lobes that he removed from the patient onto the operating side table. And he told Mark that if you can put all of them together, he would take him into neurosurgery. Just wanted to know if it's a true story or not.
I'm going to answer from the third one. It's the first time that I hear that story, but I'm sure that you know us very well, Marc. And what is wonderful is Marc and Jacques can be very funny and can invent very truly funny story. But I never heard that one. It's interesting. The second thing regarding the respect of the basal ganglia, you know that as good as me, that basal ganglia has not only a lot of connection with the cortex, but also with the thalamus, with the brainstem, with the habenula. So even if we have the impression that it's better, so far we are not able to demonstrate that by very scientifically. But I think that if more you respect the normal brain, more the patient will be better after surgery. It's common sense, but common sense can be dangerous. But as I told you from the beginning of my presentation, even if our target is to perform a hemispheric disconnection, try to keep as much as possible the normal structure intact. And the first remarks regarding the rate of shunt, it's true that all the procedure is done through the ventricle. It's the beauty of that procedure because it's very anatomical, and you do that at the top of the brain, so you have a very nice view of the brain, as I have tried to show you. And it's the reason why, starting the procedure, I place a plug of gel foam into the foramen of Monroe. And I don't know if it plays a role, but again, I think, based on common sense, if you place that plug of gel foam into the foramen of Monroe, and you avoid during all the procedure the contamination from the lateral ventricle to the third, fourth, and so on, I think it helps you to reduce the risk of postoperative hydrocephalus.
Yep. Thank you very much. It makes perfect sense. And I just have one more question. I've been for many years trying to find out the difference between the two techniques, the lateral hemispherotomy and the vertical hemispherotomy. In fact, I have a student doing a thesis with me on cadavers to delineate the true anatomical differences between these two procedures. So I thought it was a great opportunity to ask you this question, because you told me, I saw in your presentation that you started with the lateral, with the perisylvian hemispherotomy. What made you move from the lateral hemispherotomy to vertical hemispherotomy?
I think it's because I try to be as minimal invasive as possible. When you perform the vertical paramidian, you have a small opening of 15 millimeter. You have seen that I can do all the procedure to 15 millimeter. When I perform perisylvian, I had to go all around the sylvian fissure. And even if you perform a variation of the perisylvian going only through the superior part of the sylvian fissure, I mean through the frontal operculum and through the parietal operculum and going down, it looks for me a lot more complicated. The opening is larger, and I see all the time all the vessels coming from the sylvian artery. So doing the vertical paramidian, I see the vessel only through the PIA, and only once when I perform the disconnection of the genu, you see the anterior cerebral artery, and you perform the disconnection of the splenium, you see through the PIA, you see the great cerebral vein of Gallen. For me, it looks less complicated.
Thank you very much. That's exactly what I wanted to know, because we are looking at it on cadavers too. try to delineate the difference, and I'll contact you later on to help us with the study.
It would be a pleasure to work with you.
Okay, right. So
and I wish you the best, Roy.
Thank you, Christian. Yeah, I leave the floor open to the other participants who would like to ask questions. This is a unique opportunity to talk to an expert in the field of hemispheric epilepsy surgery.
We do not have any question from the audiences. Any panelists would like to ask any questions? If not, Professor Christian, I would like to ask you two questions, Professor. One regarding the infantile epileptic encephalopathy. Do you think that the recovery in the motor system over the right side in the patient that you show also partly due to the plasticity of the brain? I mean, the control of the right side of the limb is taken over by right brain hemisphere. That's my first question. My second question, Professor, what in your opinion regarding endoscopic technique? Is there any advantage compared to your technique? Thank you, Professor.
Again, I will start by the second question. Endoscopic technique is a beautiful procedure, I think, especially with new endoscope and 3D endoscope. But I must say that if you place an endoscopic surgeon on one side and a microscopic minimal invasive surgeon on the left side, I think that one will perform the whole procedure faster than the other. I think if you want to do a hemispherotomy using only endoscopic technique, it is possible, but it's again more difficult. And I think in my hospital, the administrative people are asking me all the time, do more with less time and less money. So I think that for effectiveness, cost effectiveness, navigated microsurgery is probably the best way, not the only way, but the most cost-effective way to perform that procedure. And could you repeat your first question?
The plasticity in the recovery of motor function.
But you see, when you look at the results of people performing disconnection lateral to the thalamus and the quality of recovery, that means that it's the other hemisphere which take in charge the motricity. And now for people who are, as Roy and I, when we try to keep as much as possible the basal ganglia intact, we think that the basal ganglia on the homolateral side plus the basal ganglia on the heteroside work together to recover better and yes, better the motricity of our patients.
Thank you, Professor. One more additional that I saw in your video, there is a superimposed lines, probably is indicating the anatomical structure. I would like to know that whether it's from the same patient or some form of atlas that you have drawn earlier for the patient.
It's truly the patient.
Truly the patient. And it shows the depth. I saw there's some figure there to show depth. What is that means in the depth?
The depth is the position in the space of the focal point of the microscope. Okay. And when you enter in a volume of interest, the limit of that volume is going from a dotted line to a continuous line. So it helps you to perform small opening, because before my predecessor, we were to disconnect or to remove something, it was absolutely necessary for us to find all the landmarks around what we wanted to do. But now with neuronavigation and a good knowledge, because as you know, neuroanatomy is everything, I think you can perform smaller opening, less aggressive surgery, because helped by the navigation, you recognize better where you are.
Is it time consuming, Professor, to mark all the anatomical of that patient before surgery?
It takes time, but at the same time, it's the best way to prepare your surgery. And I named that virtual surgery before true surgery. And you will lose less time during true surgery because you have performed just before a virtual surgery and you have found all the strategy. Because during the virtual surgery, you modify your strategy, you adapt your strategy so that the true surgery will be shorter and more effective.
One more last question, Professor. I saw that when you retract the brain, the superimposed image moves without the movement of the microscope. How do you do it?
But normally, if you see something moving, is relatively. It's the brain moving, but not the region of interest. And so you have the impression that the region of interest moves, but the region of interest doesn't move. It's an impression.
Okay, thank you, Professor. And for the interest of all, I would like to inform that this program also supported by Professor Bing Zhu from Shanghai. And according to him, we have almost 900 participants who join us from multiple platforms from WeChat, YouTube, and also online platform. With that, thank you, Professor, for spending your time to show us a very comprehensive surgical technique. And also,
I'm very happy now to listen to my colleagues now.
Yes, yeah. So, Professor Roy, will you stay back also, Professor, for the next lecture?
No, unfortunately not, but I was very happy to participate in this one and to see Christian's work.
You want to give your last remarks? I mean, the conclusion, Professor?
Well, thank you, Professor Raftopoulos, and you raised a lot of very important points, and I'm happy that you raised the issue of preservation of the basal ganglia as a key to keep functional status of the children intact. Now, proximal power comes from the basal ganglia, and so that's certainly the most important thing. Now I hand it back over to Professor Liu to continue the rest of the webinar.
Thank you, Professor Roy. Hope to see you in other occasion. And thank you, Professor Christian. And thanks for staying back. I would like to call upon Professor Morofuji to introduce our next speaker. Thank you, Professor.
Can I start? Do you hear me?
Yes, sir.
Okay. So I'd like to introduce Professor Yu Zhen. Professor Yu Zhen is the chief physician of the Department of Neurosurgery at Zhejiang University, China. His clinical interest is neurovascular diseases, including intracranial aneurysm, vascular malformation, cultural artery stenosis, and moyamoya disease. His expertise is surgical intervention for these neurovascular diseases. And his group has also published many basic research papers. His group is focusing on the therapeutic strategy of secondary brain injury after intracranial hemorrhage. One of the targets seems to be neural inflammation. I'm also very interested in this basic research topic, but it may be next time. Today's topic is endovascular management for blood blister aneurysm. Blood blister aneurysm are still challenging vascular pathology for both of direct surgeons and endovascular surgeons. Compared to the circular aneurysm, blood blister aneurysms are likely to rupture in the early stage because of their fragile nature. Treatment options are craniotomy, such as direct clipping and lap clipping, the parental occlusion with or without bypass. And of course, we have the endovascular option. Recently, some groups are performing flow diverting stent for blood blister aneurysm. However, there is no consensus regarding the optimal treatment for blood blister aneurysms. I think Professor Yu Zhen will share his rich experience in treating blood blister aneurysm with us, especially about endovascular management. Professor Zhen, could you start your lecture?
Yeah, okay. So let me share my screen first. Okay. Can you guys see my screen?
Yes, Professor.
Okay, sure. So thank you for having me. So thank you for Professor Morofuji for your kind introduction. And my topic is the treatment of broad breast-like aneurysm. And what is the broad breast-like aneurysm? So we call it the BBA. So BBA is a kind of aneurysm arising from the unbranched side of parent vessel. They are usually very small size and a dome shape angiography, and a very fragile wall consists of only a thin layer of adventi and a poor defined broad-based neck because of its small size and broad-based neck, fragility, and a tendency to intraoperative bleeding. Sometimes has made it very difficult for neurosurgeon to treat. So also, although the advancement in microneurosurgery and endovascular technique, but the optimum treatment of BBA remain controversial. So at this imaging, we can see that this is the right side ICA, and we think this is the BBA aneurysm, and this is the aneurysm, and then this is the right side ICA. So epidemiology and regarding the literature published, the BBA are rare lesion accounting for 0.3 to 1% of all intracranial aneurysms and accounting for 0.9 to 6.6% of aneurysm of the intercranial arteries. And how to diagnose this the BBAs? So we have like localization and dimension and shape, appearance, and tendency to rebreathing and tendency to growth, at least 6 points. So as I mentioned, so the localization, the BBA is almost arising from the no branch side artery, and usually is proximal of the intracranial vessel, like the ICA and the MCA and the ACA and the vertebral artery. And the dimension, we can see that the BBA is almost always the small size, and usually is less than 3 millimeter. And the shape is we call it a conical, and wide neck we call it a broad wide neck. And the appearance is it's like a dissecting aneurysm, and because it's a high tendency to rebreathing and due to the febrile walls, and it's a very high tendency to growth. So from some literature they published, they said it's if they have 6 points, so the aneurysm related to the hemorrhage, so and is located in the anterior or anterior medial or anterior lateral wall of the supracranial carotid artery, and located at a no-branch side. So diameter of the aneurysm is less than 10 millimeter. And the CT, MI, and DSA affirmed the enlargement of the aneurysm in a short time. And the 6 point is the wall of the aneurysm or its neck is irregular shape. So if the 1, 2, 3, 4 point must be satisfied simultaneously, and the 6 and 5 is, if we have the 6 or 5 is satisfied. And as I mentioned, the location of the BBA is usually is proximal of the intracranial vessel. So it usually is ICA, internal carotid artery, and the circle of Willis, and the other place like MCA, middle cerebral artery, and the anterior communicating artery, and the vertebral basal circulation. And but today we usually said is the BBA is we talk about the BBA is the ICA is located at the intercarotid artery. And from the literature published at 2015, This morphology aspect of breast aneurysm and noxious for surgical treatment. They divide the BBA to 4 groups. So like type 1, 2, 3, 4. The type 1 is they called the classic BBA. So the part of wall was involved and without sac. And the type 2 is the berry-like BBA, the part of wall with sac, and in which the neck is not longer than the diameter of the artery. And the part 3, they call it is a longitudinal. So long segment in which the neck is longer than the diameter of the artery. And the part 4 is the circumferential. So circumferential. So different type of the BBA, they use the different strategy to clip the BBA. So the type 1, they usually clip of the boundary artery extending to its healthy portion. And the part 2, the clipping of the sac, including part of the health wall. And part 3 is the parent artery reconstruction with tendon clips. And the part 3 is the clipping of, over the wrapping. So let's talk about the management. So we know the BBA, we have 2 different treatment options. So first of all, you can use the microsurgical strategy like clipping, like bypass and trapping, and the vessel graft wrapping, and the parent vessel occlusion. And another option is endovascular approach. We use the coils or stents, and the coils with stents, and we can use the flow diverting stents, and even some cover stent I will mention later, and the vessel occlusion. So they also have if we searched online, we have a lot of published literature. They like from the 2010, and they have 7 literatures published, and the case series is usually more than 10 cases, and like the list is they use the stent assistant coil and the stent assistant coil over overlapping stent, and the stent assistant coil, and microsurgery, and flow diverter like use the silk stent, and they use the endovascular IC trapping. So the conclusion is like the second one, the stent assistant coil and the subsequent overlapping stents are feasible and safe for BBAs. And this one like a stent assistant coil, is the stent assistant coil of ruptured BBA is technically challenged, but can be done with good midterm result. So from this kind of literature, we can show that we can see that the endovascular treatment much better than the microsurgical treatment. And they have some review and meta-analysis published. They have the conclusion is endovascular treatment seems to have low morbidity and mortality, and provide a better outcome compared with the surgical approach. But some meta-analysis says that none of the methods is superior. And the third one is the endovascular treatment seem to be associated with reducing morbidity and mortality, and to provide a better outcome compared with surgical approach. So from these 3 meta-analysis, we can see that the endovascular treatment, the outcome is much better than the microsurgical treatment. So let's talk about the treatment details. So first we have the microsurgical treatment. The first one is the clipping. So from this imaging, we can show that after we use the direct clipping. So the IC, so this is I think is the right side IC, and this is optical nerve, and this is the right IC. So after exposed before the clipping, and this is the right angle esophageal script was applied to the BBA, and the braid of script was applied along the IC trunk, and the normal vessel wall of IC was coated by a clip, and this is I think this is a preoperative 3D dimension angiographic reconstruction, and this is postoperative, and we can visualize the IC trunk has some kind of stenosis change in diameter. But some also argue that the IC BBA can be curiously explored and treated with direct clipping as the first line technique in the majority of cases. But I think even in the very experienced hand, the intracranial rupture is about 50% of intracranial rupture. So I think if you want to direct clipping the BBA, we should put the patient in the hybrid operating room. If you can control the proximal artery with balloon or some other method, and you can reduce the intracranial bleeding. And the next one, we can use the center clip. So this imaging is a center clip, and if the involved IC was dissected and the BBA was BBA, so this is I think this is left side in the BBA exposed by clipping, and we can visualize they have some atherosclerotic change on the IC, and the wide-based BBA was seen in the right side wall of the ICA, and this center clip was applied to the BBA, and this is the pre-operative and the post-operative imaging, and they have some stenotic change on the IC. So this center clip was applied, and we can visualize the patency of the left pecon. But because this is a center clip, we should mention that it's very difficult to avoid to injure the perforated artery, and if the perforated artery was injured, they have some severe neurological deficit after the surgery. And the third one, I think, is vessel graft wrapping. And this is Yasagel clip was applied on wrapping with Terraform material. And this is the post-operative 3D dimension angiographic reconstruction of wrapping the BBA in ICA. And we can use different material to reinforce the vessel wall. We can use the muscle, and we can use the cotton and Durotex to reinforce the vessel wall. But it's very difficult to identify the burden and of the diseased segment, and to obstruct the perforating, and may lead to some complication such as subsequent rebleeding or regrowing, and there is a risk of perforating injury as well. And the trapping with or without bypass, if we want to do the trapping, we should do the balloon test occlusion first, and we should evaluate the ipsilateral ICA and with the venous delay. If the venous delay is too long, we cannot just trapping the ICA without bypass. And because ICA sacrifice in the acute stage of subarachnoid hemorrhage, because the racing intracranial pressure, hypercoagulation plus, and the risk of vasospasm in choroidal vessel like PCON and ACON, result extremely poor outcome in this absence of the cerebral revascularization. So after we do the balloon test occlusion, we usually need to do some bypass, protective bypass, prior to exploration and intended clipping of the ICA. So let's talk about the endovascular treatment. So endovascular treatment we can use, like first one we can use the endovascular treatment, the ICA ligation. So this is the same thing like the trapping with or without bypass, but you know, loss of ICA patency during the first 7 to 10 days after the subarachnoid hemorrhage carry a high probability of poor outcome, as I mentioned, because the vasospasm, even if you tolerate the balloon test occlusion, but because the severe vasospasm, so the choroidal vessel like PCON and ACON, and so endovascular ICA ligation should be used very extremely careful in acute setting. So the coils with stents. So you know, the BBA is usually have not suitable for just to put some coil in the aneurysm sac, because the small size and very broad base neck, and make it very difficult to place coil in the sac. In fact, the placement of coils into the sacral compound of BBA is a potentially dangerous maneuver and may cause perforation and hemorrhage. So we should use the stent assistant coil. We should use some multiple overlapping coil. Nowadays we have a multiple choice. We can use the Enterprise, we can use the Sorrel, and we can use the LV stent for the stent assistant coil. And just to mention that we can use the flow diverting stent. So this is the flow diverting stent. And but you know, because of the pure endoluminal artery reconstruction, flow diverter device represent an appeal option for BBA repair. And several clinical serial have lent support to this concept. But you know, we use the flow divert device is also very trouble with that, because the low initial occlusion rate and some significant procedure complication rate, and early bleeding and the mortality and the morbidity. And furthermore, because we know if we use the flow diverter stent, we should use the dual antiplatelet therapy in acute stage of the ruptured aneurysm. They have a high risk of rebleeding. And nowadays we some neuro endovascular treatment centers, they use the cover stent. They have a literature published in 2017. They use the cover stenting to treat 13 BBA cases, and immediately DSA show complete aneurysm occlusion in 12 of 13 patients, but occlusion of the ophthalmic artery occurred in 2 patients, and the occlusion of the anterior choroidal artery in 1 patient. So angiographic follow-up 4 to 6 months after the procedure show complete occlusion without aneurysm recurrence in all patients, indicate a cover stent might offer a proximal therapeutic option for ICA BBAs. So now let's talk about some cases in our center. So our center from the January 2015 to November 2020, we have 43 BBA cases. So the basic information, the first syndrome of most patients is headache followed by vomiting. And 29 patients are female and 14 are male. And the mean age is 47. The median of hand-test classification is 2. The median of fish classification is 3. So 16 aneurysms located in the left and 27 located in the right. So all the patients managed by stent-assisted coil, and except one, we use the cover stent. The operation succeeded in all patients. So none of patients happened with intraoperative hemorrhage. 3 patients developed thrombosis within the stent during the operation. So follow-up, 8 patients developed a new infection after the operation, and 1 patient has a hemorrhage after the operation. And 3 patients suffered severe vessel spasm after 1 week of operation. 9 patients were found having aneurysm relapse within 2 weeks after operation. This patient is still considering of further treatment. 30 patients' MI score at discharge are no more than 2, which means they are almost leading an independent life as stated before operation. Let's see some cases. So this is case 1. It's this it's a right side IC BBA case, and this is the right side pecan, and we use the stent-assisted coil. Actually, our case scenario, because from the 2015 to 2020, so the early stage we don't have the LOS available, so we usually use the enterprise stent, or we use the solitaire stent. So, for example, for this case, it's the early stage of our case scenario. So we use the 3 enterprise stent. So this is the first 10 days after operation, and this is the 9 months follow-up. We can see the aneurysm was disappear, and this is 3D reconstruction imaging. And this is case 2, and this is a broad wide neck. We use the 2 enterprise stent. So this is immediate after the angiograph after operation. And this is 12 days follow-up, and 4 months and 6 months follow-up. And case 3 is I think it's the right side, wide neck, the contralateral to the pecan artery, and this is we use the 2 Elvis stent to use the stent-assisted coil, and this is the 6 months and 4 months and 6 months follow-up. And this is the right side anterior wall of the right ICA, and the 11 days after operation, we use this case we use 2 Elvis stent to assistant coil the right side BBA, and it's 5 months after 5 months and 13 months follow-up. And the case 5, this is before operation. We can show the right side BBA. This is aneurysm without, I think, without sac, just broad wide neck, and this is after operation. angiograph, the 1 month after operation. So this one is the case 6, so before operation and after operation, immediately after operation, and at least the 2 week after operation, we can show the currency of the aneurysm, and 3 months after operation, we can see that the BBA, the neck was the currency, and for this left side BBA, we choose first stage. We use the 2 enterprise stent, and we can see the 3 months after the operation, the aneurysm was the currency, and the treatment. We put some more coils, and we use 1 more Elvis stent, and this is 13 months after the treatment. And the case 7, and this is a right side IC PVA with severe vessel spasm. You can see the narrow of the IC, right IC, and the MC and the ACA. And so this is immediate imaging after the treatment. We use the 2 Elvis stent and 2 assistant coil, this aneurysm, and we can show the vessel spasm getting much better immediately after the treatment. This is 3 weeks after operation, and it's 7 months after operation. So case 9 is a left side IC BBA, and after operation we can visualize this 2 Elvis stent, assistant coil, and this expert CT 3D reconstruction imaging, and this 7 months later the follow-up imaging. And case 9, and this is before the operation. This is the right side IC BBA, and this is the post-operation, and there's the expert CT post-operation. Expert CT, we use the 2 Elvis, and we use kind of push and pull technique and to induce some compact mass at the diseased segment of ICA. Unfortunately, the patient has severe vasospasm after the operation, and we angiogram the patient. We can show the severe spasm of the vessel. And this is 9 days after operation. The CT demonstrates some hypointensity of the right side, and the patient have the decompression craniotomy at the 10 days. So this is the final cases, and this is a patient have a sudden headache, and this is the left side. So this case we use the cover stent. We use the cover stent to treat this patient. We use the 4.5 by 13 millimeter cover stent, and this is 7 days after the operation, and we can visualize the aneurysm was gone, but after 3 months follow-up, we can visualize some kind of recurrency, but unfortunately this patient was lost of follow-up, and so let's get to the conclusion. And the endovascular treatment of BBAs seems to have low morbidity and mortality, and to provide a better outcome compared with surgical approach. And the second one is the stent assistant coil seems to be a safe and efficient way for BBS treatment despite the high recurrency rate. And the third one is the implantation of flow diverter stents, and the cover stent may be a safe and a feasible alternative and a future direction of development. Thank you for your attention.
Thank you very much, Professor Jun, for your excellent lecture. So you covered BBS from the HOZ diagnosis to the treatment strategy, especially for the endovascular management. So I have a couple of questions. So do you usually treat the BBAs for using the multiple stenting assisted coiling, right?
Yeah.
So I think the most of cases with BBAs are hemorrhagic case. It's kind of like the emergent cases. So when do you administer antiplatelet drugs? I think it's during the procedure
Yes, that's a good point. So we use the antiplatelet drug intraoperatively, not pre-operation. And so we use depending on the patient's weight, and after we deploy the stent, we intravenously to inject some antiplatelet drug.
So you mean after deploying the stent,
yeah,
not before the stenting? Oh, okay.
Yeah.
Oh, okay. So and how long do you use antiplatelet drugs after the surgeries? So I think you're dual antitherapy.
Yeah. So usually we use the dual antiplatelet, but depends on the what kind of stent to use. I mentioned at the early stage of the our case area. If you use the EP like enterprise stent, if I just use 2 stent and for the patient to have some hemorrhage around the brain and around the aneurysm, and if the hemorrhage is I think if it's a kind of enlargement after the follow-up CT, I will maybe use the single antiplatelet drug instead of dual antiplatelet drug.
Okay, thank you. And the next question is, so recently, how do you decide on a treatment method? Like you should go for the microsurgical clipping, or you only perform the endovascular approach?
I just now I didn't mention at least a time period of our endovascular treatment case area. We have like about 15 cases for microsurgical treatment, but the outcome is much worse compared to the endovascular treatment group. So nowadays, we usually, after patient diagnosed with the BBA, we usually choose the endovascular treatment. Just the patient, if we have a large hemorrhage, maybe we still can consider about the microsurgical treatment.
That makes sense.
Yeah.
So, and another question. So you mentioned the balloon test occlusion before the parental occlusion. Do you usually perform the balloon occlusion test before the possibility of in the case of possibility of the parental occlusion?
No. Because I mentioned if you need to sacrifice the ICA, maybe you need to do the balloon test occlusion. And like for the microsurgical treatment group, maybe you usually routine do the balloon test occlusion because you needed to trap in the ICA. Right. So yeah, but nowadays I would think if the stent assistant coil, we didn't do the routinely do the BTO test. Yeah.
Well, I agree with you.
So
but-
what's your experience? Because I know you do a lot of endovascular treatment for the aneurysm. So what's your experience for the BBA cases? And can you tell us what's the situation in Japan now?
In Japan, I'm not sure, but because it depends on the institution. Because I work for the Nagasaki University Hospital, so at that time, so we kind of like the microsurgical management first, but recently, so we are changing to microsurgical to the endovascular management. So in the kind of like now it's a bridging from the microsurgical to endovascular.
That makes sense.
Okay, so are there any questions from the audience?
There is no question from the audience. Professor Raftopoulos, you want to ask any question, Professor, or any comment?
Yes, I enjoyed that lecture. I would like to ask my colleague, imagine that you have unruptured BBA. When will you recommend microsurgery instead of endovascular procedure? What are the main factors which will you push to recommend microsurgery instead of an endovascular procedure? Another way of asking that question is, when in your team will you go for microsurgery instead of endovascular procedure?
You mentioned it's unruptured BBA or ruptured?
You have an unruptured BBA. You have to treat it because you know that it's very fragile and the rupture rate is well above 20% per year. When do you think that you will imagine? When do you recommend? Because I know that you perform endovascular, but when do you think that microsurgery will be better than endovascular? You know that endovascular is a wonderful procedure, but it's also associated, as you've shown us, with a series of complications. When do you think that microsurgery will be better than endovascular? What are the criteria which will push you to recommend microsurgery?
Okay, so I think for the unruptured BBAs, because just now I mentioned that my case history is all the ruptured one. And if the unruptured one, so if the, I think it's a proximal artery is very tortuous, and if you very difficult to navigate your caster, and if you have a very experienced hand for microsurgical, and maybe that's the way you can choose the microsurgery.
Do you think that the age for you is an important factor? You have a young lady, 30 years of age, an old lady, 70 years of age. Do you think that the young age would be also a factor?
For my opinion,
for microsurgery.
Yeah, I know what you mean, and for my opinion, I think the age is the matter for you choose the different strategy. I think because nowadays I think the endovascular technique is developing very fast, and the outcome is much compared the microsurgical is much better, I think. Okay.
My last question would be, you know that 92% of the BBA are located on the ICA, and especially on the proximal medial wall of the ICA. What do you think? What is the explanation of that 92% of the BBA are all on the ICA and even on the proximal wall? Why? Why do you think it's like that?
And that's not what I can answer. Dr. Morofuji, do you have an answer for this question?
I think it's difficult. Maybe I don't have any answer. Sorry about that.
Open question.
Thank you, Professor. Thank you for a very nice discussion. On behalf of the ACNS and Professor Yogo Kato, I would like to thank both our speaker, Professor Christian Raftopoulos and Professor Yu Jun, for very nice and comprehensive talk. And also, I would like to thank both our chair, Professor Roy Thomas Daniel and Professor Yoichi Morofuji, for your willingness to chair both of our session today. With that, I would like to thank both our speakers and our chair, and see you next session. Thank you, Professor. Bye-bye.